Thank you very much indeed, Jill. Good morning, everybody. My name, as you've heard, is Chris Hopson. I'm the Chief Executive. I'm delighted, honoured, privileged to be the Chief Executive of NHS Providers. Hopefully we play, as Jill was saying, a very important role in articulating the needs of providers in our increasingly challenged system. So what I'm going to do is try and give you a tour d'horizon. In other words, give you a sense of how we think the NHS looks from our national system level perspective. So I'll cover a bit about what we think the current strategic context is. We'll then talk a little bit about our offer to governors, and then hopefully I'll have left enough time for a discussion and questions and answers. So really I wanted to talk about four things in terms of the current context. The first is a bit about money and the fact that it seems to us, have a definite gap between the funding that is available for the NHS and the service delivery that your trusts and foundation trusts are all being asked to deliver. Second, we do have an unprecedented provider sector deficit, and to put it in very stark terms, we have lost financial control of provider finances. I think you'll probably, secondly, have heard in terms of talking to your foundation trust boards that actually the operational running of the NHS is becoming increasingly unstable. We've clearly got some major workforce challenges. We're under real pressure on the performance targets. The regulatory landscape is changing. So we have a new organisation called NHS Improvement, which came into being formally this month. Hopefully, and one interesting sign, positive sign, we think, is they are trying to move towards a simpler definition of success. And at the same time as we've got this financial challenge, this increasing operational instability, this changing regulatory landscape, we're also trying at the same time to deliver probably one of the biggest and fastest transformations in NHS history. And I think really based on the fact that the existing NHS model seems to us to be breaking down, and that therefore there is a real kind of strategic ferment out there with trusts, providers, local health and social care economies trying to do different things with a strong emphasis on integrating health and care. So it feels like there's a really pretty broad agenda here. And those are the four things that I want to talk about in terms of the current context. If you haven't read it, hands up in the room who's read the 5-year forward view. Okay, so about probably just over half of you. Can I encourage you, those of you who haven't read it, to read it? It's a relatively easy read. I think it's well written. It does provide the longer-term strategic policy framework for the NHS. It was a couple of years ago, but it really tries to set out what's happening over the following 5 years. Three key gaps that the 5-year forward view says we need to close. The first is close the health and well-being gap by better focusing on prevention, close the financial gap through a mixture of savings and extra funding, close the quality gap by reducing unwarranted variation in care, and move to new integrated models of care by bringing together what are currently separated in terms of health and social care, primary and secondary care, and physical and mental health care. And it seems to me, and this will be a recurring theme of what I'm saying, is it seems to me, and I was visiting Dorset County Hospital yesterday, we had a very interesting discussion with the board where we were really saying that it seems that in a sense the biggest challenge for providers is how on the one hand do you balance those short-term operational pressures with at the same time the need for longer-term transformation, and that will come out I think as a theme as I go on. So we are in the middle of the longest and the deepest squeeze, financial squeeze in NHS history, and that has ended up with an unprecedented provider sector financial deficit. So if you look at the top left, if you look at the numbers of trusts in deficit, 11% in 2012-13, 27% in 13-14, around 50% in 14-15, and at the year-to-date at third quarter, in this year, more than 3/4 of trusts in deficit. And if you look on the right-hand side, a net aggregate sector deficit of a minus 100 million at the beginning of 2013-14, we pretty confidently predict that we will end 15-16 with a £2.8 billion deficit, which is unprecedented. And I've tried to put on the bottom the reasons as to why we're seeing this increase in deficit. So ever since the NHS was created, inexorably it seems to an increase in demand and cost every year of about 3.5%. Up until the Blair-Brown years, surprise, surprise, NHS funding increased on average by 3.5%, but actually, and I'll give you the detailed statistics in a second, actually, if you look at the years between 2010 and 2020, NHS funding increases are way below what we have historically received. So you've got the combination of the rising demand and cost, the low funding increases, a 3-4 year period in the between 2010 and 2015 where, to be frank, the centre was asking for an unrealistic set of efficiency savings at 4% a year, which no Western health economy has ever delivered. You will remember that we've added probably somewhere between £1.5 billion and £2 billion of extra unfunded staff costs since the Francis report, and as a result, we have this unprecedented deficit. I would make the point that, and I'm echoing the Public Accounts Committee and I'm echoing the Health Foundation recently, this is not due to individual provider performance. This is not due to boards, executive teams not performing effectively. If you've got 76% of the sector in deficit, it's due to a structural system problem. And I'm not for one moment pretending that, we can't all do better. Clearly we can. But the idea that somehow this is a fault of some substandard provider leadership teams seems to me to absolutely not be true. This is actually about a structural problem that actually requires a structural solution. And trying to whip providers harder to get them to do better is not the answer. So this is really the macro picture on finances. So on the left-hand side, I've put the funding increases the NHS can expect, and I think many of you have heard of this wonderful concept of the front-loaded spending review, which effectively means the increases for the NHS were absolutely put into the first year, the year we're now in, where the NHS gets a 3.6% increase. 17-18, 1.4%, and then to us, a wholly unbelievable 0.4% in 18-19, 0.6% in 19-20, and then rising a bit again to 1.4% in 2020-2021. And those, by the way, are the NHS funding increases. There's another, that's about on about £100 billion budget. There's another 10 or 11 billion that is held centrally by the department, which has been actually, and goes on things like Health Education England's budget, that's been cut by 30%. So in fact, the increases for the Department of Health as a whole are lower. And as I was saying, the NHS in its first 65 years, the annual average increase was 3.6%. Between 2010 and 2020, we will have a 0.9% at yearly average increase. So it's a quarter of what the NHS is used to. And as a result, GDP per head spending on health and care is going to drop by 2021. So effectively what we're saying is we are in this middle of this longest and deepest squeeze in NHS history. So what's the response been? Well, last year, you will remember, there was increasing what we would describe as central grip, where effectively the arm's-length bodies and the department tried to get a tighter grip of provider sector finances. Lots of initiatives, for example, caps on using agency staff, insisting that we spent less on capital and moving that to the revenue budget. You will hopefully be in the middle of a debate, or probably shortly in a debate with your executive teams about the operational plans that were due in at the beginning of this week. And effectively what the centre is trying to do is to use a process whereby it agrees a financial control total with every single provider, foundation, trust or trust, and effectively uses that to try to control what each individual trust's financial position will be in 16-17. As you might imagine, there is an interesting debate going on between the centre, who are trying to get each individual foundation, trust and trust to agree a stretching financial target, and each board or many boards who are saying, hold on, that's too stretching. And again, I had a very interesting debate with board members in Dorset County Hospital yesterday about what was a reasonable stretch and what was an unreasonable stretch. The problem is that, if we try and look to reduce that provider sector deficit in 16-17, and there is extra funding to do that, the problem is if we get back on the straight and narrow, it still doesn't look particularly attractive longer term. And for us, there is no current realistic plan to realise the required £22 billion worth of efficiency savings the NHS really needs to stand still over the rest of this Parliament. And as I've said earlier, I think those funding increases of 0.4 and 0.6 currently look impossible. So we're left slightly scratching our heads by effectively saying this is meant to be the easiest year of the Parliament, and if you talk to all of your boards, I think you'll find that they are deeply pessimistic about their ability to deliver what's needed in this supposed year of plenty. So I think that does give you some indication of what the financial pressure looks like. Clearly, the operational pressure is growing. Left-hand side is a screenshot from the BBC's website from a week ago, basically saying that the A&E target has been performance is at its record new lowest level since the target was introduced. And so we now have the position where providers are consistently missing operational performance targets across the range of targets. Not entirely surprising when in February many trusts were reporting a 10% year-on-year increase in A&E presentations and a 3, 4 or 5% increase in admissions. And surprise, surprise, if you run your hospital at 95, 96, 97, 98%, which is unheard of in Italy, Spain, Germany, France, etc., then if you get that sudden demand spike, it's not entirely surprising that the whole thing clogs up and you then get a drop in performance. So again, and I think all of you talked to us about this, there's a real sense of the impact of the pressures on primary and social care coming on secondary care providers. There is clearly growing acuity from an older and iller population with more complex comorbidities. And I suppose one of the things I've been thinking a bit about over the last kind of 6 months is clearly, and Jill, I thought, put it very, very well, is we have some fantastic advantages from a taxpayer-funded system, which is there's a real sense of equity, which you just simply don't get. You know, access to care based on clinical need, not ability to pay, is pretty fundamental, and that's a great advantage of a taxpayer-funded system. However, I would make the observation, having worked for party politicians in my earlier career, is they do find it difficult to acknowledge when there is a gap, and there clearly is a gap, and we have a bunch of politicians who are at the moment, and to be frank, it's of all colours, who are unwilling to admit there is a gap, especially at a point where actually they probably feel they can't afford to close it because we are in the middle of this period of austerity. So our kind of sense is there's a real kind of pressure growing here, but having party politicians in charge of the NHS, which is one of the consequences of a taxpayer-funded system, does mean that actually it's difficult to get the quality of national debate that we need about whether that gap exists and how to close it. I don't know about all of you, but I think we feel that we seem to be somewhat walking into a workforce crisis. Our kind of sense is that we feel that the staff are bearing the brunt from that gap between the money and what's required to be delivered, and there's a real sense they're just under increasing pressure. We do seem to have some very large structural workforce shortages. Some of them are regional, some of them are national. But if I talk about the shortage in A&E consultants, the shortage of, for example, paramedics, the shortage of nurses, and there doesn't seem to us to be a particularly credible plan to really address those long-term structural workforce shortages. I think a growing feeling that our central workforce planning system isn't really fit for purpose. Is it really credible to say that we can restrict public sector pay to pay rises for 1% for a 10-year period? That would be unprecedented. We seem to have found ourselves at war with our junior doctors, a key part of our workforce. I think a worrying bit for me, because we see all the wiring at a national level, is that strategic responsibility for workforce is split between 4 national bodies and also between local and national. I think we've got a much more mobile, younger workforce that actually doesn't see the employment deal in the same way that we used to see it, in terms of that real sense of working for a single employer for a much longer period. And I think, again, you might kind of come across this in the work that you do, a really quite unsupportive, I think, top-down culture in which it's quite finger-pointy if things go wrong, and not particularly supportive, recognising the burden that we're asking our provider leaders to bear. So I think a kind of sense that if we're not, we feel like we are definitely heading towards a workforce crisis. Are you depressed yet? It's a pretty gloomy picture, isn't it? So, at the same time, the regulatory environment is changing. From the 1st of April, NHS Improvement combines the old Monitor and the Trust Development Authority. I think it's fair to say that it's a different approach, and that fifth bullet point down, I think the new leadership team is much more about what's going to work, as opposed what does the regulatory framework say. And I think a real sense that they feel their job is to recover finances, help the sector recover finances and performance, and that requires a degree of short-term grip. There is a commitment to longer-term earned autonomy. Quite what that means we're in the process of working with NHS Improvement about, but I think it just does feel very different from the heady days of you became an FT and you had complete freedom to do whatever it was that you wanted to do. It now feels more command and control, more grip from the top down. To be fair, I think there are some good things that are happening. There is a simple, clearer single measure of success that I'll come on to in a second. There is also more emphasis on support and helping build provider leadership capability. So what does that clearer, simpler definition of success mean? Well, I think if you ask the new Chief Executive of NHS Improvement, who used to be a Foundation Trust Chief Executive of long standing, he'd probably basically say, well, what I'm looking for is for people to get a CQC good or outstanding rating, to get back into financial balance and realise the Carter savings, deliver your core NHS standards and performance targets, and then really help lead transformation of your local health and care system and move to new care models. Trips off the tongue nice and easily, doesn't it? Do you know how many trusts currently have got either a combination of a CQC good or outstanding rating, are in financial balance and are currently meeting their performance targets? So there are 238 foundation trusts and trusts. There are precisely 5 who actually have got the combination of those 3 things. So actually it's just an indication of how far the sector has to go to actually meet what some might regard as kind of some really pretty basic success criteria. Again, just to stress the point, I do not believe that is somehow the responsibility of the leadership teams. It's actually, many of these problems are systemically driven. We are going through a change in terms of the Foundation Trust pipeline. So the pipeline is still flowing. So congratulations to anybody from Oxford University, Birmingham Community or Sussex Community who've recently gone through the pipeline and become Foundation Trusts. There now are 155 NHS Foundation Trusts. So given there are 238 trusts and Foundation Trust providers, that means 60% or more, just over 60% are now Foundation Trusts. However, it is increasingly clear that there are a significant number of NHS trusts who will not be able to become FTs within a reasonable kind of period. And also at the same time, I think we've got 2 other trends, which is a growing interest in larger groups of providers, chains, groups, potentially mergers, and a real sense of shared back office functions. And I think there's also, and again I'll come on to this in a bit more detail, a real sense of moving from focusing on individual institutions to focusing on whole local health and care systems. So I've talked a bit about the operational challenge, I've talked a bit about the money, I've talked a bit about the regulatory system. Let's just talk a little bit about the transformation. So the thesis is that the existing NHS model of care provision is rapidly breaking down. I think there is a temptation with where we are at the moment, where the money's going wrong, we're missing the performance targets. There's a temptation, I think, to run harder and harder and faster in the existing model. My hypothesis, our hypothesis would be that actually that is not a sustainable solution, that actually trying to run harder and harder in what is increasingly feels like a broken model doesn't work. So our kind of sense is, and I'll explain this in a little bit of detail, is that we think that in reaction to that kind of basic principle, there is a strategic ferment looking for a different way of doing things, boosted very much by the 5-year forward view. Clearly, implementation on the ground is being driven by a combination of the new care model vanguards, which I'll talk about in a second, and then also by the new sustainability and transformation planning process. Hands up who thinks they know a little bit about the sustainability and transformation planning process out of interest. Okay, so very few of you. Okay, I'll come on to that in a second then. Good that I've got a slide on it then. So let me just talk a bit more about why we think the existing kind of model is breaking down. So at the moment, again, I don't know about you, I joined the NHS 3.5 years ago, and the thing that just completely zapped me between the eyes straight away was how incredibly fragmented our health and care delivery system is, how incredibly fragmented, you look in each area, it is between primary care and secondary care, how incredibly fragmented it is between physical and mental health care, how incredibly fragmented it is between health and social care. So I can talk about it in terms of look at the number of organisations that you have to deal with in a local system. So, a whole bunch of GP practices, probably 2 or 3 CCGs, 2, 3, even in some cases 4 providers, the local authority on social care, lots of different organisations making it incredibly difficult to kind of coordinate. If we look at it from the patient's point of view, we consistently get feedback that actually they're dealing with 25, 30 different people from those different organisations on their care pathway in a year, and it drives them up the wall. I think a real sense that we've also got an NHS that particularly in our sector is about treating illness as opposed to ensuring health and well-being. And I think a real kind of sense that a real preponderant weight in terms of the influence of medical professionals in the system. I would argue quite a hospitalised model, that the model effectively is you're ill, we whip you into hospital, we do something to you, and then you come out and you're well, which, used to work, but as you're about to hear, I don't think works for a lot of conditions these days. And the real sense that the kind of hospital was the real dominant kind of force in the local health and care system. And interestingly, a real trend towards specialisation, a kind of real sense that, hospital care is now dominated by increasingly specialised specialists. You're no longer a cardiologist, you're actually the expert in the left ventricle, as opposed to, more generalists. And I think a real kind of sense that we have an NHS where the service structure and the service patterns are really on the basis of history, and there is understandably a real emotional attachment to existing buildings and institutions. And I suppose what I was going to try and say to you is, why is that model breaking down? And here are a few reasons. The first is there's no doubt that the burden and the pattern of disease is changing, that whereas these, in the old days, something happened to you, you whipped in the hospital, did something, out you came. Actually, that doesn't work with long-term conditions. It certainly doesn't work with multiple comorbidities, where effectively, actually, people are living with illnesses when they've recovered from cancer, when they've got diabetes. They're living with these conditions for 15, 20, 25, 30 years, and they're not amenable to a single hospital-oriented intervention. You suddenly become well again. I think a real kind of sense that, one of the key challenges, arguably, for our country as a whole is we do have a rapidly ageing population and rapidly rising and changing expectations. We've clearly got huge technological change, which is the opportunity for actually to support patients to play a much greater role in managing and supporting their own health and well-being. We've also got huge scientific and clinical innovations. For example, I think genomics is going to completely change the way we provide healthcare. We've also got the long-term pressure on health and social funding. So we talked a bit about we're in the middle of this 10-year squeeze, the 10-year deficit reduction programme. So a real kind of sense that all of these are providing big challenges to the existing model. So what we see is a real kind of sense of strategic ferment. Whenever I go out and I talk to boards, we get the real sense of their thinking, how do we do things differently? How do we move towards an existing model? Move towards a different model. And I've just tried to put on this kind of ring around the strategic ferment some of the kind of things that people are talking to us. It's very clear quite a few people are talking about vertical integration. So in other words, how do we, in our local health and social care community, bring all of those different disparate bits together to provide a much more seamless pathway of care, to ensure that actually we're all working together much more effectively. Quite often that going round clockwise brings new organisational forms. Quite often there's also a greater emphasis on prevention. What's also interesting is we see quite a few people talking about horizontal collaboration as well. So, for example, I visited, I was up in Dudley, Walsall and Sandwell and West Birmingham about 2 or 3 months ago, where you've got 3 DGHs, about 20 minutes travel time between them, all 3 of them trying to provide a complete set of full services. And they're asking the question, actually, does that make sense? Why don't we have 1 rheumatology service, 1 dermatology service, 1 urology service? Because actually, not only would it save money, but actually we simply haven't got enough consultants to provide 3 different services across 3 different DGHs. So a real sense of people beginning to look to how do they work with their neighbours. I think some real blurring, as we've said, between the primary and secondary boundary. Went to Wolverhampton 2 weeks ago. They are one of the very first. They're in the middle of taking over 3 GP surgeries. The GPs came along to them and said, we can't make this work anymore. Would you like to take us over? So again, a real kind of sense that actually people are beginning to blur that boundary. We've talked about integrating physical and mental health and greater switching to patient self-care. Went to Airedale about 1.5 years ago, where they've got a really interesting approach to telemedicine and telehealth, where they've done some fantastic things with their local care homes. So if you're in a local care home and something may be going wrong, you can just literally plug in this little briefcase, and then you've automatically got a screen right in front of you, and you can talk to somebody at the hospital. Cut admissions by 50%. We've also talked about joint provision of health and social care. I don't know whether you saw yesterday, but in the Health and Service Journal, North Devon is now getting into the provision of domiciliary social care. I was talking to Ipswich 2 or 3 weeks ago, they're doing the same. So a real kind of sense that different people are kind of doing different things. And we've actually got this now formalised in the system in that we now have a number of different vanguards who are centrally funded, £116 million in 2015-16, to actually look at how might we move towards new models of providing care. They have some slightly clunky names: multi-specialty community providers, integrated primary and acute care systems, enhanced health in care homes, acute care collaboration. If you go onto the NHS England website, you'll get a real sense of what these organisations are doing. But what they're doing is looking at new models of care. And although we think it's going to go rather slower than some people would like, we think that over the next 5 to 10 years, everybody will be moving towards these new, more integrated and different ways of providing care. So, you may remember, or you may know, that effectively, at the moment, the real focus, in the second bullet, is that most organisations at the moment are planning with a single-year operational plan for your institution. What everybody's been now asked to do is to work on a strategic multi-year place-based plan to set alongside those operational plans. So the idea is that everybody should come together in a local place, local authorities as well, address the wicked issues and develop a long-term plan to transform care and plot a path to sustainability long-term in the area. So in a sense, each organisation is asked to, carry on doing your single-year institutional-based operational plan, but also let's also do a multi-year place-based plan. So there are 44 footprints that have been decided, and there are people who've been allocated as coordinating leads, half of whom are provider chairs or chief executives. Those plans are due to be submitted by the 30th of June. I would assume that your local leadership teams will be beginning to talk to you about what they have in mind there. So let me finish off by basically just talking a little bit about our offer to governors. Let me say to start with that one of the reasons I took this job is that I think the whole FT model is absolutely fascinating. I think there are 2 key bits of FTdom that I think absolutely really resonated with me. The first is Whitehall simply cannot run 238 trusts and foundation trusts, and the whole principle of vesting authority and autonomy with a unitary provider board to really run and take responsibility for each of those organisations, each of whom, to be frank, is a large organisation. Average 150, 200 million turnover, many employing many thousands of staff. it's right that they should be autonomous organisations. Second key principle is it's absolutely right they should be accountable to their local communities through the member and governor model. And I think it's a really interesting model, and I'm a huge fan of it. And actually, one of the things I'm trying to do over time is persuade government that it's a model that should be adopted in other public services. Clearly, in that role, engagement and constructive challenge from governors is fundamental. So I think I worked out relatively quickly that there seem to be two broad ways that boards treat governors. One of them is lock them in the cupboard and only let them out when you want them. The second is to recognise they can be a real fundamental force for good, and that actually if you involve them, support them, engage governors properly, they can make a massive contribution to the running of the institution. And in a sense, the more you put in, the more you get out. I hope you will all realise that I'm in favour of this model. I'm not in favour of that model, and we clearly do everything we can to encourage boards, chairs to realise that their governors are a fantastic resource that needs to be used effectively. So our view of the fundamental role of governors is that effectively, as NHS Improvement may be exerting more grip while providers return to financial balance, there will be a return to earned autonomy. The two pillars of FT status, board autonomy and local accountability, are fundamental, enabling providers to move forwards in tough times, and they are absolutely compatible with the move to new care models. We believe the Council of Governors are fundamental to providing local accountability for services, as well as routes to involving members, staff, patient service users, carers and the public in the work of the Trust. And we therefore will be strongly continuing and putting a real emphasis on our work to support Council of Governors and their boards. And we'll also be supporting NHS Improvement in developing their model of earned autonomy. And I've just noticed Stephen Hay from NHS Improvement walking in. He's the next up, so if you want to probe him on what that means, feel free. And also exploring what earned autonomy might mean for trusts as well as foundation trusts. So we think your role is fundamental. So we think that the contribution we can make in supporting you is being clear about the scale of the challenge going forward, advocating hard on a range of issues of which tariff and payment systems are very good examples to ensure that providers are resourced to deliver high quality care, and ensuring that we're central in the key national conversations. And in terms of actually what we provide to you, we want to offer a combination of something that goes to everybody, but then also bespoke support as needed. And I hope you'll feel that the work that we've done to create a national development programme for governors govern well, the quarterly newsletter that we do, the dedicated website that we do, development of online resources and tools, and sharing good practice at events like this is helping support you to do your role. We would, of course, always like your feedback on what more you think we can be doing. I certainly would like to do more, but it would be helpful to get your sense of what you would find particularly helpful. So let me finish by saying I think it is tough times, I think it's difficult, but I really want to stress that I think the role that you have to play is fundamental, and we are really committed to supporting you to do that role as effectively as possible. I hope that's been helpful.
I'm Tobias Payne. I'm from the Peterborough and Stamford Hospitals NHS Foundation Trust. Something which is the big issue is the Office of Fiscal Studies study between 2010 2018, reduction in local authority budgets of 30%.
Yeah.
Now that's the very big issue. That's the issue which I feel has never been actually addressed, because it is a major problem. And of course, foundation trusts, everyone's foundation trust, 95% are in deficit, as NHS trusts are as well. So what's the position relating to the fact that, yes, people can't get to their GPs because they want instant access, so they turn up at the A&E department, they know the doors are not going to be closed. The trusts can't discharge people, delayed transfer of care, so the trusts are of course fined for the delayed transfer of care. There are lots of discussions about joining together, partnerships and things like that, but the partnerships can't deliver, perhaps as a result of the reduction in local authority budgets. The fact also, the Royal College of Nursing stated that between 2010 and 2015, we lost 50% of our nurses in the community.
Yep.
So we need nurses in the community, we need all manner of services. Mrs. Jones, who's free to be discharged from a hospital, her medical condition is now better, she needs community care.
Okay.
She doesn't care who she receives it from. But
Yep.
why are we still discussing this issue?
Can we?
Okay, thank you.
We got that question. There's one on this table and one here. We'll take three.
Pat Malloy from Sheffield Health and Social Care Trust. And thank you for that, Chris. You did open up by saying that you're going to discuss meeting the needs of the providers. And of course, I would hope that that would also run in tandem with meeting the needs of the patients.
Yep.
One area in particular that I think has got a complete wrong priority is the huge difference in the treatment of mental health conditions and physical health conditions.
Yep.
So, for example, very few people die from a broken leg, yet you'll get treated within hours. The
Yep.
number of people that die from, say, depression or an eating disorder, where the time for treatment is not measured in hours, maybe not even weeks, quite possibly months. There's a huge discrepancy there, and I wonder what is going to be addressed by that topic.
Okay, thank
and
you.
Third question.
Thank you. My name is Anita Hyam. I'm the public governor and also the lead governor for the Oxford University Hospitals Foundation Trust. Thank you for an excellent presentation, but you missed one bit out.
I missed lots out.
I humbly dare to say.
No, of course.
I have been much exercised by the nature. We only became Foundation Trust last October the 1st by the fact that I carry this label, and I said I'd do it for a year, called Lead Governor.
Yep.
I contacted what was then Monitor, now NHS Improvement, and said,
Yep.
does there exist nationally any sort of group of lead governors across all the Foundation Trusts? No, she said, but that's a really interesting idea. They did try to have one some years ago, but it fell apart. She was most enthusiastic and encouraging that I might attract a number of lead governors to try and explore this on the surface, simple role. We've got to tell Monitor if our foundation trusts are not compliant with their license, if the evidence is there. But in reality, it turns out to be a bit more complex. And so we are having a long conversation, a group of us, telephonically speaking, I'm not very good at remembering the language, next Tuesday, about whether we might proceed. So if there are any other league governors here who are interested in exploring further whether we might get some benefit from meeting together, coming together, learning together, exploring together, perhaps then we can talk to Chris and say, please, could you think about the nature of this complex role? My view is that some obscure, distant civil servant, when they were designing Foundation Trusts for the 2006 Act, thought, oh, that's a good idea. We've got to have somebody who links it and call it lead governor. But anyhow, I'll leave the rest to you.
Okay,
all right. So I can do the third one really simply, which is we would love to work with you to see how we might support you gathering together a bunch of lead governors more effectively. And I can see our Director of Policy and Strategy talking to the chair of our Governor Policy Board about exactly this issue. Yes, nods from there. So yes, I think why don't one or both of you come and have a conversation and let's see what we can do to kind of help. And certainly it's something that I think would be a really good idea. So the problem when you do a presentation like this is that you can absolutely kind of, you can mushroom. And in fact, I already went on far too long. But the two issues that were raised, both here and here, I absolutely agree with. Then clearly local authority budget cuts are a really significant issue. And it's very clear. Interestingly, it's not just for me about the impact on the social care, but those of you who pick up local authority contracts, for example, public health contracts, sexual health, all that, there are really, really under pressure. So we think we're having it tough in the NHS. Actually, if you look at the local government settlement, it's a lot worse. We argued very strongly, along with a bunch of other national bodies, that in the spending review announced last October, the government really did need to sort this out. They pretend they have. I don't think they have, and the reality is, yes, there is a social care precept, yes, there is more money coming in towards the back end of the Parliament, but exactly as you're saying, sir, by shaking your head, it's not enough, and that is something we are continuing to push. In terms of mental health, again, I completely agree with you. It seems to me every time I talk about this, everybody trundles out the phrase parity of esteem and says, look, we're trying to do our best. But in reality, I still think we are not doing as much as we could. To be fair, the introduction of the treatment targets in certain areas of mental health provision, which happened this year and more last financial year, and there's more coming this financial year, will at least start to make a difference. But we've just completed a piece of research that shows, despite very clear instructions in the planning guidance last year, and we suspect this financial year, that CCG should increase their funding on mental health, that hasn't happened. So again, it's an area that we are deliberately and will continue to campaign strongly on, because we feel as strongly as you do that actually it's an area that needs proper and appropriate support.